Right. Yeah, I think I do need a new mouse. It kept double clicking on me a while ago. And I got this little pin here, this little cool little pin here. It's supposed to be able to draw on the screen, but apparently my battery's dead. So I think I left it on in my backpack the other day. Or something. And they're quadruple 4 batteries or quadruple A batteries. Like 4 A's. Apparently it's pretty tough to find. For me anyway, I guess. All right, so today we'll be going over chapter 32, which is going to be abdominal and genitourinary or genitourinary injuries. GI. That's probably what you'll hear me substitute that with, because you know how tongue-tied I get. Canchire. All right. That's weird. What about 31? Is 31 on there?
$31 is on there. 30 is literally the only one not. I'll send you a screenshot.
No, I believe you.
It's weird.
If you would, can you also turn in a help ticket? I guess you go. I don't know how it looks on your screen, but I went to the help and what have you, the support, and went up there and turned in a little help ticket or something like that. That's odd.
Yeah, I'll do one.
Okay.
That is weird.
At the top of the screen, or do you have a little on the side? Do you have a little sidebar that shows like calendar, quizzes, and all that good stuff?
Yeah.
When you click on quizzes on there, does it do the same thing?
Hold on, let me check.
Okay. That was fast. Awesome. The Sprite is very fizzy.
Come on. You staying up here with Daddy? Come on, Jackie. Come on.
What'd you put in it?
Honey and sugar and milk.
Put milk in it. Thank you. I'm lactose intolerant. She put milk in it. She's trying to kill me. Anything show up?
Okay, it's showing up in my quizzes now and it's open, but it's not showing up in my grades. It's weird.
Okay. So yeah. So try it there. See if it'll open up. You're right. Beggars can't be choosers. And I'm definitely a beggar. Yeah, usually there's on that sidebar. It does that, or it works out pretty well. So I don't know. Anyway, that's good. We're making progress with that then. All right, so National EMS Educational Standard Competencies. We will So introduction. The abdomen is the lower of the two major body cavities. The first one being thoracic cavity, and then abdominal cavity. It's going to extend from the diaphragm, which is the bottom of the thoracic cavity, down to the pelvis. Okay. And it contains organs that make up digestive, urinary, and GI systems. Any of these organs, they may be injured, but some are better protected than some others. You must know where these organs are located and understand their functions. That's going to be the big important thing, is knowing where they're located. So whenever you're doing your checks, whenever you're doing your assessments, then you'll be able to better understand what's going on with your patient at that point. So injuries to the abdomen that go unrecognized or untreated are a leading cause of traumatic death. There should be a high index of suspicion, and prompt treatment is going to be required for those. Okay. And a lot of times, if you have those abdominal injuries, especially abdominal trauma, is you will definitely see in your assessment some signs, and the patient will have some symptoms that will be quite noticeable. And then also putting your hands on your patient, things like that, that's really going to be what makes the difference there. Does anybody remember when we talked about auscultating or listening to the abdomen? Does anybody remember that? And how long we were talking about it actually takes to hear abdominal activity, or if you're trying to hear any gut sounds or anything like that. So if you're doing a true auscultation of the abdominal area, it takes almost 4 minutes to be able to get a true feel of how everything's working. Now, sometimes you get in there and you can just hear it grumbling around. And you know that something's not right, or you may hear some strange sounds in there, that it's overactive for some reason. All right, so anatomy and physiology review. Abdominal quadrants. The abdomen, it's divided into 4 quadrants by 2 perpendicular lines that intersect at the umbilicus. Okay. No problem. Got you, Leanne. No problem. All right, so you got, and you're gonna remember these. You got right upper quadrant, which in your documentation you can just put in there RUQ. You got left upper quadrant, LUQ. You got right lower quadrant, which will be RLQ, and then you got left lower quadrant will be LLQ. But nobody can guess where that came from, where we got that from. So the quadrant location or bruising or pain can delineate which organs are possibly involved in a traumatic injury. The diaphragm is going to be the dividing line between the thoracic and abdominal cavities that we talked about. And it may be injured along with abdominal organs. And if the diaphragm is injured, it's pretty traumatic, and it's usually very painful. Some other things too is like we talked about when we did thoracic injuries, is that if you do have a perforation of that diaphragm, your innards can actually end up into your thoracic cavity if it's a bad enough injury. So which would be fairly traumatic if I had to take a wild guess. All right, so hollow organs and solid organs. And it's important to know these, and it's important to know these because of certain trauma, how that those different types of organs are going to react to certain types of trauma, to a blast injury or to blunt force trauma or to GSW or something like that. they're gonna react differently if they're blood filled or if they're hollow, or if they're solid or they're hollow. So owing to the size of the peritoneal cavity and the structures it includes, a patient could lose all of his or her circulating blood volume into this area without any visible external bleeding. But again, you're going to see some major signs if that happens as well. They're going to be pale, pale, pale. And, you know, like we've talked about before, they're going to start shunting and everything else. So arms will be cold, hands will be cold, fingers will be cold. They'll be very pale looking or jaundiced or what have you, depending on the injury. So hollow organs, including the stomach, the gallbladder, intestines, the ureters, and urinary bladder are structures through which materials, other types of materials can pass. They're more resilient to blood trauma and less likely to be injured by trauma unless they are full. So like if your bladder's full and something happens, or stomach's full and something happens, or, you know, so on and so forth. So use the bathroom every chance you get. So solid organs are solid masses of tissue that include the liver, the spleen, the pancreas, and the kidneys. Abdominal pain from penetration or rupture of solid organs usually have a slow onset. It's zero sugar Sprite. It's just not the same. And it's very fizzy. All right. So different organs of the abdomen are contained in the peritoneum, which is in, so you got A here. Move my cup. You got A here, which is the retroperitoneal space. You have B and I'm sorry, I had that wrong. You have A, which is the peritoneum. You have B, which is the retroperitoneal space, and then you have C, which is going to be the pelvis. All right, you can see what's in each one of them. Peritoneum, retroperitoneal space, and pelvis. A, B, C. So the GI system, it's going to be composed of the reproductive system and the urinary system. The urinary system controls the discharge of certain waste materials filtered from the blood by the kidneys. The kidneys are solid organs. The ureters, bladder, and urethra are all hollow organs. Right? The reproductive system is going to control the reproductive processes from which all life is created. Also, in that GI, so something to think about is that in your entire GI system, when we start getting into it, you got to think of it like this. It is an outside environment inside of your body. So if that outside environment inside of your body comes in contact with the inside environment of your body, you could, of course, it's going to create issues of contamination, things like that. So pathophys. So injuries to the abdomen are considered open or closed and can involve hollow or solid organs. Okay. There are some general pathologic concerns. Hemorrhage can occur when there is external or internal blood loss. Signs and symptoms will vary greatly depending on the volume of blood lost and the rate at which the body is losing blood. Wonder if I can get Rob this weekend to bring some a whole bunch of fake blood or blood packets or what have you. We'll do a little project. Some key indicators of hemorrhagic shock will become apparent with the assessment of the neurologic and cardiovascular systems, like I've been talking about. You're going to see those key indicators if you have a good bit of blood loss in the GI area. I don't know why I keep drinking it. As hypovolemia increases, the patient will initially experience agitation and confusion. If it's left untreated after that, hypoperfusion will result in anaerobic metabolism and acidosis, like we talked about before. So peritonitis. So what do you think that is, peritonitis? It's going to be inflammation of the peritoneum, right? And then pneumoperitoneum, okay? So injuries to hollow or solid organs can result in the spillage of their contents in the abdominal cavity, that outside environment spilling inside. So the pain is localized if the extent of the contamination is confined. Pain becomes generalized if the entire peritoneal cavity is involved. So peritonitis is usually you have an intense, potentially it could be a life-threatening inflammatory reaction to that. So some of the first signs are going to include severe abdominal pain, tenderness, and some muscular spasms. So pneumoperitoneum, it may also occur as a result of a rupture of a hollow organ, or a perforated peptic ulcer, recent abdominal surgery, or a rupture of an abscess also can happen. Peritoneum secondary to hollow organ rupture requires surgical intervention, by the way. So they're going to have to go. All right, and this is a picture of some bruising here, you can see. You can see all that. All right, so closed abdominal injuries. A severe blow damages the abdomen without breaking the skin. So if you have a closed abdominal injury. So compression injuries are typically caused by a poorly placed lap belt, deformed hollow organs, increasing the pressure within the abdominal cavity is going to create some issues. Deceleration injuries commonly occur when a person or a vehicle in which he or she is traveling strikes a large immovable mass. That was weird sounding tonight. It's strange. All right, so this here, you can see this type of injury here. Just pay attention to those patients. So crush injuries are the result of external factors at the time of impact. So you think crush, it's not like a blunt force trauma where you've been hit by something and it releases. Now you got something that's crushing down and it's going to hold there. And we've talked about all the issues that can come with crush injury, from, you know, the trauma that's involved to how it creates buildups of lactic acid, traumatic rhabdomyolysis. It can also create, you know, tamponades. It can create a plethora of injuries. So shearing. And in those crush injuries, the solid organs are going to be at the greatest risk, by the way. So shearing, it may cause tears from the ligamentum teres hepatis is what it says. I'm going to have to, some signs and symptoms of this are going to be pain, tachycardia, decreased blood pressure, pale, moist skin is going to be some of those signs and symptoms. It's going to be pretty marked whenever you see it, marked when you see it. They're going to be very pale. Just for reference, nope. Now I got it. So just for reference, that is a belly button. Just for reference. And we'll talk why. So you can see here, crepitus in the lower rib, Kerr sign, and bruises. So crepitus in the lower rib areas may indicate broken ribs. Kerr sign. There's pain primarily. It's going to be located in the right lower quadrant, RLQ, and can indicate an inflamed or ruptured appendix. Okay, that's what you're looking for. So RLQ, appendix. Okay, right lower quadrant, appendix. Pain that follows the angle from the lateral part of the hip to midline of the groin can be the result of damage to the kidneys or the ureters even. When you're determining the location of the pain or referred pain, it can be more difficult when the patient has voluntary or involuntary guarding. We know what guarding is, right? Okay. And they're holding in, they're not, you know, they're leaning over on one side or what have you, guarding. Referred pain. Who can tell me what referred pain is? Like when it hurts in your shoulder, even though it's abdominal. Right. It's referred. It's somewhere else. So like you know, back pain or side pain, in some patients that have that are having myocardial infarctions, they may have pain in their jaw, and that's a referred pain. Okay. All right. And then bruises in the right upper quadrant, right upper quadrant, left upper quadrant or flank might suggest an injury to the liver, spleen, or kidney, respectively. All right, you'll see bruising on the sides here. Okay. Does anybody remember what that's called? When you see bruising on the sides, on the flanks? Anybody remember that? We'll come back to it. I think it's in here later on. What about bruises around the umbilicus? This here. Does anybody remember what that's called? So it's going to be predictive of pretty significant internal abdominal bleeding. And it's called something. What do you think? Any idea? Take a guess out there. It won't hurt anybody's feelings. Not even your own, I promise. Bruising around the umbilicus. Oh, I know you know the answer. You watch Twilight. You're a big Twilight fan. Your favorite character's last name is the name of it. You're full of it. Give me that mess. So it's going to be Cullen sign. Cullen, Cullen sign. So that's going to be bruising around the umbilicus. If you see Cullen sign, you got to think significant internal abdominal bleeding. Big issues. You'll see other things too. Low blood pressure, shunting, cool pale skin. But you did know he was a vampire. Gotcha. Bust. Yep. When you had your camera on the other day, I saw it in the background, the poster. It's okay. You can still kick it. Oh. All right. So injuries from seatbelts and seat bags. Injuries from seatbelts and airbags. Seat bag. They do have seat bags that are on seatbelts now, but we're not talking about those. So seatbelts occasionally can cause blunt injuries to the abdominal organs. Thanks, Hannah. Thank you for correcting that. If the belt lies too high, it can squeeze abdominal organs or great vessels against the spine, which is no good. You can see that in the picture here. And then small children and short people like myself, who are in the front seat of an automobile, it could be at risk of injury for when the airbag is deployed. Airbag comes at you at about 200 miles an hour. So we've seen, if any of you have worked scenes long enough, you've probably seen it on airbags where you can see a perfect face print from the lady that likes to wear a lot of makeup. So it looks like a clown has headbutted her airbag on its way out. Anybody ever seen that? Yep. You'll see everything. You'll see mascara. You'll see a lot of stuff, lipstick. You'll see a lot, the powder and everything, or base and all that. They'll smack it and you'll see a face in the actual airbag. It's pretty wild. 200 miles an hour. So it's coming at you pretty fast. And also talk about, leg injuries and things like that. Yep, it'll break bones. One of the things that always gets me, driving down the highway and you pass somebody and there's somebody in the front seat, most of the time on the passenger side with their feet on the dash, feet sitting up on the dash, or feet curled up next to them. That always makes me cringe because of how many accidents I've been on and seen the results of what happens when you pull your knees up. You see a lot of this. They got their knees up here, driving or whatever. I'm not even gonna do all of it because it hurts as it is. Or they got their feet propped up on the dash. It can jack a lot of things up, and a lot of times, a lot of wrecks involving younger females, I see it a lot, is their leg up like this while they're driving, because they drive like this or like this. And so you'll see a lot of that, their knees all the way up here and everything, and they have a wreck and it crushes everything. It's pretty rough looking. All right, so whenever you do come across a wreck, you want to make sure that you inspect the bag or you inspect beneath the airbag for signs of damage to the steering wheel. So what you're looking for is signs that they could have hit the steering wheel either on the bottom, which would be most of the time could possibly be their abdomen, or the top, or their arms. You want to take a look at that. You can see there, rebar, making a statement there with the rebar. So open abdominal wounds is a foreign object enters the abdomen and opens the peritoneal cavity to the outside, which is not good. You always need to assume the worst, that organs have been damaged, and you got to provide prompt transport, get them out of there. Gunshot wounds are most commonly involve injury to the small bowel, the colon, the liver, and other vascular structures. In penetrating trauma from stab wounds, the liver, the small bowel, the diaphragm, and colon are the organs most frequently injured. Oh no, where are his gloves? He's gonna have to put them things on. So we call this an evisceration. Whenever your bowels are protruding through the skin, that is an evisceration. So it goes all the way through the skin and the muscle layer and through the fascia, and it results in the bowel protruding through the actual skin out there on the outside. Some of the signs and symptoms that you're going to see are going to be tachycardia. There's going to be evidence of shock. You know there is a distended abdomen from the accumulation of blood and fluid. And then if major vessels are cut or solid organs are lacerated, bleeding may be rapid and severe. So just some things to expect there. we had an old boy in Hattiesburg. I come pulling up to the house and get out, walk up, and this guy's smoking a cigarette out on the porch, right? He's sitting in a chair, in a lawn chair, smoking a cigarette. He's a big old boy, got a big old gut. And when I walk up, he's not wearing a shirt. He's wearing shorts, which he's got such a big gut, you could barely tell he's wearing shorts, you know. But you can see blood coming out from the bottom of his shorts. He's smoking a cigarette there. Said, "Hey, what happened?" He said, so-and-so threw some of my books, and when I got in his face, he cut me. First off, the guy was somebody that he invited in his house to stay in his house. Had a stranger up in his house. The guy cut him with a K-bar. He cut it, is what he said. It was a K-bar. If you don't know what a K-bar is, it's a large knife. It is a very large knife, like Rambo style knife. So anyway, I went to, I told him, I said, "Hey, I'm going to have to take a look before we get you up and see what's going on. Where's it at?" He said, "It's right here. It's right here." And he pointed to his belt line. I was like, "Okay." So I raised up his belly. And when I raised up his belly, he said, "Oh, that hurts." And I looked and I could see his innards bulging out right there on the edge. This guy had gut in him. All right. And his belly was what was holding it in. So at that point, I was like, "All right, well, we got to take you in." And sat there and we get, he's like, "Can I finish my cigarette?" And I was like, it's your life. It's your life. If you absolutely can leave, let's go. If you absolutely have to stay and smoke that cigarette, suck it down. Let's go. Hurry up. So we get this old boy loaded up, and we put him on the stretcher. And he was a big old boy. And this was back before motorized stretchers. This was the pick up, break your back stretchers that we had. So anyway, as we're going, we get him onto the stretcher and get him in the ambulance. And we go to give him an IV, and he starts complaining about the IV. He said we hurt his shoulder, and then he's talking about how much pain he was in because of the IV. And the medic was a pretty darn good medic. He hit it right off the bat, and he was griping at how much the IV hurt, but yet his guts were hanging out. So I'm saying, speaking of, as I'm sitting there, I can see his gut starting to bulge out. I had to take an ab pad and hold an ab pad, a wet, we doused it down, and I took an ab pad and held it to his guts to hold him in, right? We get all the way to the hospital. We get in there, and this nurse, and I mean, there's a lot of blood coming out at this point. His blood pressure, I still remember his blood pressure this day. It was 84/45. 84/45. And so we get to the hospital, we get him rolled in, and I remember I'm sitting there, and they put him up on the hospital bed, and of course they got him laid back. So I'm holding his guts in, right, with this wet ab pad. And this nurse comes in, and she's like, "You can let go. You can let go now." And I'm like, no, you don't understand. I'm holding his contents in. And it's fine. It'll be fine. I said, "No, there's a lot of blood. It's going to spray blood." Because it hit some pretty good vessels in here. And she said, "It'll be fine. Just let it go. You have to leave anyway." So I obliged her, and I let it go. And she was like, "I'll get it." And just as she said, "I'll get it," a spray of blood hit her right in the face. I'm talking about hosed her. And I was like, outwardly, I was like, shock. Oh no. And inwardly though, I was like, told you so, So she didn't want to believe me. She did believe me after that though. Anytime I came in with injuries or anything, but we didn't have anything like that. We had some other good ones, but nothing like that at the time. He went to surgery, and they fixed him right on up, and he wheeled out of there smoking a cigarette and all. Sorry, that was a longer story. All right. So injuries to specific structures. So injuries to the diaphragm. If the diaphragm is penetrated or ruptured, abdominal organs can be pushed upward into the thoracic cavity, like we've talked about. Patients are going to exhibit dyspnea. Why do you think that is? Because their guts are where their lungs are supposed to be, right? They feel short of breath. They may have abnormal respiratory sounds. I don't know why. And they may have a abdomen that's sunken in or concave anterior wall. That's because all their guts are out and their guts are up here. All right, past the diaphragm. It's going to be painful. They're not going to be able to breathe very well. And the likelihood of you fixing it or not, there's no likelihood. You're not going to fix it. That person needs hospital, needs surgery. So positive pressure ventilation is definitely going to probably be required. Patients with a ruptured diaphragm may become very anxious and short of breath if placed in the supine position, so laid back. So you don't want to lay them back anyway, because where's those guts doing? They're rolling. So you want to try and get him up, keep as much down as possible. But you may have some major signs of ventilatory compromise in that case. So injuries to the kidney. So kidneys are the most commonly injured organs of the GI system, right? So blunt renal trauma is what we call that. It's what results when the kidney becomes compressed against the lower ribs or the lumbar spine. Blunt renal trauma. So a ruptured kidney, it will usually present with pain on inspiration in the abdomen and flank areas. So abdomen and flank areas, right? So penetrating renal trauma is more likely to be associated with injury to the liver, lung, or the spleen. Injuries to the kidney rarely occur in isolation. So a penetrating wound that reaches the kidneys almost always is going to involve other organs as well. So you do need to suspect kidney damage if the patient has an abrasion, a laceration, contusion, or hematoma to the flank region. Okay. Penetrating wound in the region below the rib cage and above the hip or upper abdomen, where what I like to call my spare tire area. Right up in this area, the whole Michelin man. Fractures on either side of the lower rib cage or of the lower thoracic or upper lumbar vertebra. You may also suspect, or you should have a pretty good index of suspicion for kidney injuries. All right, so injuries to the liver. So liver penetration or rupture, it could quickly lead to signs of shock. Why do you think that is? Full of blood, right? Bleeds heavily. So a liver injury must be suspected in all patients who have right side chest trauma as well as abdominal trauma. Right side chest trauma as well as abdominal trauma. Okay. So there's going to be referred pain to the right shoulder, or there may be, sorry, not a guarantee, but there may be referred pain to the right shoulder if this happens. So injuries to the spleen. So the potential for rupture is going to be much higher if the spleen is enlarged from mononucleosis. Mononucleosis. We talked about that a long time ago, I know. When the spleen ruptures, large amounts of blood can spill into the peritoneum, which can ultimately cause shock and death. So spleen, not a good thing to be splitting up. So you got to suspect spleen lacerations when there's fractures to the 9th and 10th ribs on the left side if are present. 9th and 10th ribs on the left side. Patient's left side. All right, so injuries to the pancreas. It typically takes a high energy force to damage the pancreas. Patients with pancreatic injury tend to present with vague upper and mid-abdominal pain that can radiate into the back. So the patient may also develop a peritoneal irritation hours after the injury. Injuries to the intestine and the stomach. So the intestines are most commonly injured from penetrating type trauma. Can be injured from severe blunt trauma as well, though. And that blunt type trauma, it may come with resulting in peritonitis. So blunt trauma to the abdominal wall most commonly causes injury to the duodenum. The duodenum. So the injury may present as back pain also if you have those type of injuries. Contamination of the retroperitoneum. Where's the jejunum? Have you ever been punched to the jejunum? Were you talking about the movie? Not yet. Yeah. So the jejunum it's pretty close to the duodenum. Let me see if I can find it exactly where there's not like right on it. It's in the same abdominal area. Let's see here. Do you remember the name of that movie? By any chance? So the duodenum, as you know, the duodenum is from the stomach to the going towards the small intestine. The jejunum on the other hand is going to be lower. It's about let's see here. Can you see it? Duodenum near the stomach. The jejunum further down into the small intestine. Yep, semi-pro. That's right. That's right. Let it go. Oh, you're talking about Frozen. I was talking about semi-pro. Will Ferrell. That's what I'd say too if I was a secret Twilight fan. All right, so injury to the urinary bladder. I'm gonna blow that up. I don't know if anybody can see that. It's not really. You can see the injury here that it's trying to show you. It's just very small, or maybe it's just mine. All right, so injury to the urinary bladder. Bladder injuries are usually associated with pelvic fractures. So if you think bladder injury, probably a pelvic fracture is going to be, or a pelvic, if you think pelvic fracture, because that's going to be what you see or what you feel more of and see better signs of. So like the legs laid out or what have you, you can automatically think there's a good possibility that you have a urinary bladder injury. So blunt injuries to the lower abdomen or the pelvis can often cause rupture of the urinary bladder as well. If a bladder rupture results from a sudden deceleration type force, the urine may be spilled into the part of the abdominal cavity, leading to things like intraperitoneal, extraperitoneal, and retroperitoneal ruptures. All right. Injury to the external male genitalia. So testicular torsion can occur as a result of trauma. It's time sensitive and it's going to require rapid transport. Injuries to the testicle or the scrotal sac. So it can end up with a loss of fertility. If it could be a major concern when a patient sustains a testicular injury. So the exact outcome is going to depend on whether the testicle can be preserved via definitive treatment. So if you can preserve that testicle, I guess you would place the testicle from the sac into another sac, possibly. So blunt testicular trauma can result in simple contusions, rupture of the testicle, and in rare cases, torsion or twisting of the testicle. All right, so penis injuries. So injuries to the penis may result from blunt or penetrating trauma, but may also arise from different types of sexual behavior or self-mutilation. We've probably all seen the videos. A fractured penis may occur when an erect penis is accidentally impacted against the partner's pubic symphysis, or if it's bent too far because of self-manipulation. Penetrating trauma to the penis most often results from gunshot wounds. So most often, gunshot wounds are the result of penetrating trauma to the penis, oddly enough. Injury to the female genitalia. So uterus, ovaries, and fallopian tubes are rarely damaged because they're small, deep in the pelvis, and well protected by the pelvic bones. Penetrating trauma to the reproductive organs may result from stabbings to the lower pelvis or gunshot wounds. As pregnancy progresses, the uterus enlarges substantially and rises out of the pelvis, and it's making it vulnerable to penetrating and blunt traumas. So expect to see signs and symptoms of shock with pregnant patients as well. They're already using enough blood as it is, or the baby's already using enough blood as it is. If they have any type of injuries, that's even more that they're going to be even more of a problem where you have a hypovolemic shock issue. So supine hypotensive syndrome. Who knows what that is? Supine hypotensive syndrome. Who can tell me what that is? And we're still on pregnant patients. So in a pregnant patient, think of supine hypotensive syndrome. What do you think that's the cause of? Or what do you think causes that? Yep, blood pressure goes down when lying down, but what causes it? Why does that? What do you think happens for that to happen? Or what do you think causes that? I'll figure out a way to say it in just a minute. You know what I mean. Okay. What do you think the baby could be pushing on? Just think, you're laying on your back and you have a heavy object inside your body pushing on something and causing low blood pressure. What do you think that the baby's possibly lying on? Yep, a descending aorta or something like that. That's absolutely correct. So one of those great vessels, right? Or one of those arteries. The baby is laying on that. So what position do we lay that patient in? And what side do we usually and women usually sleep in whenever pregnant? Or preferred, or what doctors prefer them sleep in? Yep. Left recumbent. That's right. That is correct. All right, before we jump into this, let's take a 10-minute break. Then we will come back. All right. See you in 10 minutes. Can you hear me now? Holy cow. So I did the whole, all right. I tried to do right and still didn't do right. So instead of muting myself on the computer here, I muted myself on my microphone right here. And yep, I hit the little mute button and then I didn't even think about the computer here in front of me.
Hello.
Hey,
Hey,
The whole family's watching.
okay. Well, then I'll try and get it right this time. So I was talking about the lightning. I was like, the lightning is popping off outside like crazy. And I was like, so I'm just waiting for any minute for it to knock out my internet and everything else. I can see that starting to get a little laggy. I just had it worked on too, so I don't know what kind of speeds I'm getting right now. I don't know what I should be getting, but anyway, if it gets knocked out, it gets knocked out. No big deal. I'll put something up on Discord about anything else. All right, so vascular injuries. Before it gets knocked out, let's run through it. Blunt trauma can cause injuries to vascular structures in the intraperitoneal space. That's often, it can be masked by other types of injuries. The significance of the injury is going to depend on how many vessels were injured and the length of time that has passed since the injury occurred. So some of the assessment findings are going to differ depending on whether the bleeding is contained or if there is active hemorrhaging going on at that time. All right, so abdominal aortic aneurysm, or AAA, not to be confused with AAA out of certain areas that we live, work, and deal with. It might have developed and become worse due to abdominal trauma. Abdominal aortic aneurysm, AAA, just like it sounds. All right. And actually, somebody can insanguinate inside of their body within a very short amount of time.
I love you. Bye. Car don't love you. Bye.
Yes, he does.
MDK and Car do love you. Bye.
So where you at?
Where are you at? I love you. Car do love you.
Awesome. Awesome. All right, so just like it sounds like an abdominal aortic aneurysm, AAA, you can bleed out fairly quickly because of that alone. Usually they talk about, or some of the stuff that they say is there's a burning in the back, a burning in the stomach area, or something to that effect, some sort of burning or some sort of sharp pain. But also you'll see other signs, low blood pressure. There'll be that major shunting will cause that cool pale skin, things like that. It happens very quick, and they need to get to a hospital in a hurry. All right, so rectal bleeding is a common complaint of that as well, and something that you may encounter as a chief complaint. Some of this can be caused by sexual assault, rectal foreign bodies, hemorrhoids, colitis, ulcers of the digestive tract can also cause this. Well, I'm tongue-tied up. All right, so your patient assessments. So the cause of an abdominal or GI injury may be readily apparent as a result of the MOI, but the resulting damage may not be so apparent. Okay. So maintain a professional presence at all times when whoa, that was crazy. I had the blinds down and I saw that whole streak of lightning with the blinds down. That hit close. So maintain a professional presence at all times when treating these types of injuries. When examining the patient, expose only what is needed and then cover up what's been exposed. So you're seeing size up. So scene safety is your first consideration, always, right? And then follow your standard precautions. Eye protection is required when managing open injuries, and look for indicators of MOI, and consider early spinal precautions. Oh, didn't mean to do that. If the wound is penetrating, inspect the object of the penetration. You may have to stabilize that object. With GI injuries, you want to be aware that the patient may avoid discussing the injury to avoid undergoing a physical examination. If the patient trusts you, you're more likely to learn the true facts behind some of these injuries. So your primary surveys, you're going to evaluate that patient's airway, breathing, circulation, your ABCs. You're also going to evaluate the D, disability, and E, exposures. So A, B, C, D, E. And then you're going to immediately care for any life threats in those areas. So you want to make sure you control any external hemorrhaging and look for indications of internal bleeding. The evaluation of a patient who has abdominal or GI trauma must be systematic. The systematic process, like we talked about over and over and over again. Always make sure that you treat life-threatening external hemorrhaging before airway or breathing concerns. Follow that X, A, B, C, D, E mnemonic. So if you suspect shock, you want to treat the patient with shock according to your protocols. Perform a rapid full body scan of the patient. If you find a life-threatening problem during the scan, stop, treat it immediately, but examine the abdomen closely, looking for decap BTLS and things like hemopperitoneum, blood in the peritoneum. All right. I keep hitting the wrong button. So in your history taken, obtain a history of present illness, OPQRST, that's going to be important. If the patient's not responsive, attempt to attain a sample history from friends, family, or whoever's nearby that may have witnessed it. Ask whether the patient has, if they're conscious, ask whether the patient has any nausea, vomiting, or diarrhea. Ask about the appearance of any bowel movements. What does it look like? That's where we're looking for that tarry stool, bloody stool, things like that. What's it look like? And then urinary output to check. You want to see if there's possibly any blood. What does it look like? The incidence of repeated or previous injury or illness involving the GI system can help determine the extent of the current injury and possibly that mechanism of injury. So the secondary assessment, it may need to happen at the ED itself. You want to make sure that you obtain a full set of vitals, including the pulse rate, BP, respirations, oxygen saturation, mental status, skin condition, pupils. If you can get that capnography, if they look sick, remember, sick patients, do it to it. If the patient's experiencing external internal hemorrhaging, monitor the vital signs closely with a degree of suspicion that there could be a lot of internal going on. So you want to repeat the patient's primary survey in your reassessment and reassess their vital signs. So remember, stable every 15 minutes, unstable every 5 minutes, right? So you want to identify trends in pain. You want to identify trends in your vital signs. You also want to identify the progress of your treatments and communicate the MOI and the injuries found during your assessment to the hospital staff. So document the results of the physical examination and any pertinent negatives. I really want to see pertinent negatives in y'all's reports whenever you start doing the charts. All right, so assessment and management of specific injuries. So patients presenting with blunt injury and evidence of substantial abdominal trauma are potentially not reliable, okay? They should undergo spinal immobilization or spinal motion restriction. High flow oxygen should be administered to them, and consider the use of a PASG or a pneumatic anti-shock garment. Remember the pants, the inflatable pants? And that's going to be for an unstable pelvis if it's dictated by your local protocol as well. So most abdominal trauma requires rapid transport to the closest, most appropriate facility and provide emotional and psychological support en route. That's going to be important because these people are going to be in a lot of pain, or they're going to feel like it's going to be the end. So sometimes lots of pain come with that. All right, so closed and blunt abdominal injuries. A patient with a blunt abdominal injury may have one or some of these combinations of severe bruises of the abdominal wall, laceration of the liver or the spleen, ruptures of the intestine, the gallbladder, or the stomach. There may be tears in the mesentery, ruptures of the kidneys or avulsion of the kidneys from the supporting structures, rupture of the urinary bladder, severe intra-abdominal hemorrhaging could be going on. We've talked about how to look at that. Peritoneal irritation and inflammation in response to rupture or hollow organs, rupture to the hollow organs, sorry. If you do suspect an injury of the diaphragm, you want to focus on airway breathing, right? And circulatory status on those patients if you suspect a diaphragm type injury. And then also remember that diaphragm type injury, you may want to put them up in a semi-Fowler or Fowler's position for that. You want to make sure that you immobilize any patient who's sustained a blunt abdominal injury. Also monitor those patients' vitals for any indication of shock. That's why we do that trending, right? And then keep the patient warm. We're treating for shock. Keep that patient warm and provide for prompt transport to the ED. We've talked about that before. Our biggest thing that we're looking for in trauma is to protect against, have it up. Oh my goodness. That lethal triad, right? Lethal triad. All right, so in all of our patients who are experiencing trauma, we want to make sure that we're going over our lethal triad. All right, we're protecting against that at a bare minimum. If you're, that's going to be your bread and butter there. Now, who remembers the lethal triad? Who can tell me? We've talked about it a few times. So let's hear one leg of it. Okay. So that's that. You're thinking of another type of triad. And the lethal triad, we're looking at a couple of things. You got, see if I can do it. Hypothermia. Yep, you're doing one of them. Hypothermia being one, and y'all should be able to take it away from there. So what's next? Acidosis, awesome. Looks like my kid wrote it. What else? One more. I don't know why that happened. I didn't even make that shape. If I had my pen, it wouldn't look like that. So hypothermia, acidosis, and coagulopathy. Okay. The lethal triad. Always think about how to mitigate the lethal triad. All right. So how do we mitigate hypothermia? How do we mitigate hypothermia? Right. Keep them warm. Keep the patient warm. Turn the heater on in the back of the truck. Keep the patient warm. Okay. Making sure that you don't give them cold fluids, right? We're not giving them cold fluids whenever we're giving. All right. Acidosis. How do we mitigate acidosis? Oxygen. Yep. Okay. And how do we mitigate coagulopathy? How do we mitigate coagulopathy? Yep. Also, there's something that as an AMT you can do too. And it also helps mitigate acidosis. It can, depending on what's going on. Fluids, IV. Give them the IV. You ain't sleeping on me, are you? All right. I thought I did that. It's weird. All right, so open penetrating abdominal injuries. So patients with the penetrating injuries generally have obvious wounds and external bleeding, and we're going to mitigate that if we can, or if we need to. Only a surgeon's going to be able to accurately assess that damage. So you want to follow the general procedures that we previously had that we described for blunt trauma. If your penetrating object is still in place, don't remove it. We can call whomever to be able to shorten it or be able to maneuver around it. Whatever we got to do, we just don't want to remove it because we don't want to cause it. And we want to try and keep it stabilized as much as possible. So bulky dressings, things like that. So also in that case, you're going to initiate how many 18 gauge lines, or I don't like that it says 2 18 gauge IV lines. We're looking for what? A better term is always large bore IV. We're looking for a large bore IV. And also during your practical, your practical exercises or your psychomotor, if you use the term large bore IV, that's a winner. That's a winner. All right. When you start to get into specifics, they can hone in on you. So abdominal eviscerations. During the assessment of evisceration, do not push down on the patient's abdomen. Why not? Oh, Ty did that. I see. So you don't want to push down on the patient's abdomen. And the reason being is because you don't want to squeeze that thing like a pimple and guts come out, right? Simply put, you don't want to do that. You don't want to cause further injury. You also don't want to try to stuff the guts back in there. Now, can you take the guts and put them on top? Yes. Don't try to shove it back into the cavity. So you want to make sure that you cover it with a sterile gauze. You want to make sure that you cover it with a sterile gauze, and you want to secure them and with a dry sterile dressing. So the sterile gauze, it's going to compress moisten with sterile saline solution. Okay. And then you secure it with a dry sterile dressing, just to make that clear. Sterile gauze compresses the moisten, moist with, I hate that word, with sterile saline solution, and then secure it with a dry sterile dressing. Keep it moist. So also you're going to provide other care that's going to be needed too. Make sure high flow oxygen, and then transport according to whatever local protocols that you're doing. Oyster than an oyster. That's right. That is disgusting. Oh, I see. I see. I see. There we go. How's that? That actually may be a better way to do it than using the what I was using. All right, so the open abdomen is going to radiate body heat rapidly. Man, you're bleeding it. You're bleeding anyway. You're going to be off. You know, blood is what helps keep warmth, the circulating blood and everything else. That patient is going to be hypothermic. So you're going to cover the wound with a moistened sterile dressing and with an occlusive dressing. Of course, that's also going to be dependent on your local protocol. And then secure that dressing with a bandage, a dry bandage, and secure the bandage with a tape. As you can see here. We'll see if this works. Oh my goodness, this works so much better. Yep, that works a lot better. Thanks, Ty. So the kidneys, you're going to see signs of shock if the injury is associated with significant blood loss. Another sign of kidney damage is going to be blood in the urine. Also, you're going to treat shock and other associated injuries in the appropriate manner, as always. You're going to provide that prompt transport to the hospital, monitor the patient's vital signs, and just keep them hooked up while en route. Keep it running, keep it going. So the urinary bladder, you're going to suspect a possible injury to the urinary bladder if you see blood in the urethral opening, okay? Or physical signs of trauma on the lower abdomen, pelvis, or the perineum. The presence of associated injuries or shock will dictate the urgency of the transport also. What we talked about, urinary bladder, what do we say a lot of the cause of urinary bladder injuries are? That's right. Pelvic fractures. This is so cool. Now I've got this new toy. And it's actually working correctly. All right, external male genitalia. A few general rules apply to treatment of injuries. So the injuries are going to be very painful. You're going to use sterile, moist compresses for those to cover the areas that have been stripped of any type of skin. You're going to apply direct pressure with a dry, sterile gauze to control any type of bleeding. Never move or manipulate any impaled instruments or foreign bodies in the urethra. And a lot of times, my wife can tell you, her working in X-ray and in CT, especially in X-ray, is that an abnormal amount of teenagers come in with different types of insertions, male teenagers with insertions in the urethra. Some of the things have been like pencils, pens, the little, have you ever seen the little BB magnets? She had a picture one time that she was able to show me. A training purpose was, it was the magnetic BBs in the urethra and like settled in the bladder. Crazy. So you never want to, so you never want to apply a constricting device to the penis to control bleeding. And explain all the procedures to your alert patients to reduce anxiety. It's already going to be a stressful situation for that. Testicular torsion should always be suspected when there was direct trauma to the testicles. Okay. So transport those patients to the injuries, or with those types of injuries, rapidly to the ED, get them off your hands. And the thing about it is you want to make sure that those hospitals also have ultrasound capability and an available urologist. So you may need to contact, when you contact that hospital, mention that. You may need to write, hey, do you guys have ultrasound capability and a urologist? This is what we're running into. And possible plastic surgery. You don't want to attempt to remove any type of tight objects from around the penis, the testicles, or both. So don't do that. Don't remove any of that. It happens. All right, female genitalia. So lacerations, abrasions, avulsions, they should be treated with a moist, sterile compress. Use local pressure to control bleeding, and a diaper type bandage to hold dressings in place. You want to leave any foreign bodies in place and stabilize them with a bandage. Bleeding could be very heavy, but it's usually controlled by local compression. Okay. Contusions and other blunt injuries are, they all require careful in-hospital evaluation. The urgency of the need for transport will be determined by the associated injuries, the amount of hemorrhage, and the presence of shock. I need to ask Rob if he'll bring fake blood, or if he's got fake blood packets, because I really want to. I always feel like that's a good reminder of how much blood is a lot of blood, and in different scenarios, in grass, dirt, and on concrete, it's always good to do. So if you believe that your patient's been sexually assaulted, do not examine the genitalia unless obvious bleeding requires you to apply a dressing. There's going to be evidence that may need to be collected, anything like that at that point. Okay. Also, some of the stuff that you don't, if that's a suspected deal, you don't allow the patient to try to take a shower, all that good stuff, if you suspect any type of sexual assault. All right. Anything or any questions that anybody has so far up until this point? Because the next slide is going to be our 4-digit code. Okay. So our 4-digit code for tonight is 5414. That is 5414. And that'll get you into the test. 5414. All right. All right, so I'm going to stop recording.